Everyone, this is Jennifer Yost at Health Evidence, and it's my pleasure to welcome you today to our webinar regarding a systematic review about interventions with potential to reduce sedentary time in adults. So just before we get started today, we wanted to let you know that we will be using some polling questions to gather some information about who's joining us and your familiarity with the topic today and systematic reviews. And we would just like to let you know that we will be using this information to plan for our future webinars and to also possibly inform the production of future systematic reviews in this session. But overall, the purpose of the polling questions is to stimulate engagement and discussion throughout the session. And you can feel free not to answer any polling questions that you would not like to answer, and you can also please provide responses if you would like. So just to let everyone know that after today, the PowerPoint and audio presentation will be made available via our via our SlideShare and YouTube accounts, and we will post those links, or they have been posted actually already, within the chat section on the right-hand corner of your screen. And so thank you again for joining us today. We are going to hear from Anne Martin, who's the first author of this systematic review about interventions with the potential to reduce sedentary time in adults. And for those of you who would like to view the summary by Health Evidence, you can click on the link that has been posted in the chat, and you can also link out to the full text of the systematic review as well, and that link has also been posted in the chat. Our first polling question today will help us identify what sector are you from. So public health practitioner, other, education, research, provincial ministry, policy analyst, or other. So thank you to all of you who are responding, and it appears that the majority of the people joining us today are public health practitioners. We have a few participants joining from research, a few joining from the provincial, territorial government, ministry, and municipality sector, and a few others who have indicated other. So thank you to all of you who have answered this polling question. It gives us a good idea who is joining us today. So just a few housekeeping items as we go through our webinar today. And this is just to let you know that you can use either the Q&A or chat in the right hand of your screen to post comments and questions during the webinar. Feel free to send it all of your questions to all panelists. But if you do accidentally hit just for the host, I will get that as well. And what we'll do is at the end of this session today, we'll have a question and answer period where I will ask your questions of the author. So please, even during the session today, feel free to post questions as we go along. For connection, the best connection, we recommend that either wired internet connection versus a wireless. And we posted the 24/7 helpline to WebEx also in the chat should you need any technical assistance. And that's to listen, obviously, for our audio through your speakers. And then you can go to communicate an audio connection to listen through your computer speakers. And so we'd like to find out how many people are watching today's session or listening in to today's session with you. We've been finding that lots of people have been joining us by groups, and that is some people are doing that today. So most people are joining in just by themselves, but we have a group of 2 to 3, a few groups of 2 to 3 people, and a group of 4 to 5 people. So thank you again for everyone who has joined us today, either personally or within a group, and thanks for providing a response. Oh, and we have a group of over 10 people also joining us today, so quite wonderful. Thank you so much for your interest. And so just to orient you to our health evidence team, here is a look at all of those who are involved in helping health evidence achieve its mission and vision on a daily basis. And as you can see, there are many people who work to keep health evidence current and maintained. So thank you to all of those people who work with us here at Health Evidence. And just to give you a bit of background about Health Evidence in case you're not familiar with our organization, Health Evidence was launched in 2005 and is a comprehensive registry of systematic reviews focused on the effectiveness of public health and promotion interventions. So we provide over 90,000 visitors per year access to over 4,300 quality-rated systematic reviews. So every systematic review that you will find on Health Evidence has received a quality rating out of 10, with the closer to 10 being the greater or the better quality systematic reviews. And in addition to quality rating the systematic reviews, we provide full links to the full text, some plain language summaries as well. And one of the goals of Health Evidence, in addition to making evidence about the effectiveness of interventions more accessible, is to make it easier for health professionals to use evidence in decision making. And so a few reasons that we strive for here at Health Evidence are to save you time. Again, all of these systematic reviews have been quality rated, and they are a result of a wide search. The evidence is relevant and current, again, relevant to public health interventions. It's a transparent process, so there is further information on our website about how we do search for the systematic reviews and how we do rate them, as well as our quality rating criteria. And at Health Evidence, we also provide some support for evidence-informed decision-making with some tools that are located on our website. And the feedback we've gained over time is that Health Evidence is easy to use. And so for anyone who is not familiar, this is a model for evidence-informed decision-making in public health. And you can see there are 5 components visible from this model. And what we've found in our work over the years is that we're really good at addressing the community health issues of the local context, the community and political preferences and actions, public health resources, and incorporating public health expertise into decision making. But what we're probably not so good at, or we can do better, is incorporating the research evidence into decision making as well. And as such, our webinar series here at Health Evidence are designed to identify research evidence that's relevant to public health decisions to hopefully make it easier for those to consider research evidence in their decisions. And this is our evidence-informed public health wheel, which illustrates the steps of evidence-informed practice. And it's really used to guide practitioners and decision makers in addressing an issue systematically. And so while we here at Health Evidence go through many of the steps, what you will find and you'll hear about today is how the presenter has worked through the first 4 steps in order to help you as decision makers with the remainder of the 7 steps. So just another polling question when we talk about those steps in the process of evidence-informed public health. One of the first step is defining the question. So wondering how many of you have heard of the PICO or PICO-S acronym before. And thank you to those of you who are answering. The majority of people have heard of the PICO-S before, and a few have not. So for those of you who are unfamiliar with this acronym, it stands for the population or the situation, the intervention or exposure, the comparison or the other group, the outcomes, and the settings. And our presenters today will reinforce this acronym as well and how it is used in systematic reviews. And so as we talk about wanting to help you here at Health Evidence to use research evidence in your decision making, we'd like to get a sense of how often you use systematic reviews to inform programs and services. And this can be individually or at an organizational level. And so the majority of people are saying often, and then we have some saying sometimes and always, and a few saying never, that they have not used a systematic review to inform programs and services. So thank you all for your responses to that question. And getting to our presenters today that have joined us from the UK, my pleasure to invite Anne Martin, who is a postdoctoral research associate with the Physical Activity and Health Research Center, Institute for Sport, Physical Education and Health Services at the University of Edinburgh, and Nanette Mutrie, who's Professor, Director of Physical Activity for Health Research Center, Institute for Sport, Physical Education and Health Sciences, also at the University of Edinburgh. And before I turn it over to our presenters today, what we would like to get a sense of is, because we're going to have our presenters talk to you about a systematic review that they've conducted about this topic, we're wondering what your thoughts are before we get started. Do you think interventions can reduce sedentary time in adults? And so thank you to all of those for responding. The majority of people, Anne and Nanette, are saying that they agree or strongly agree. We have a person who is neutral as well. So we'll be interested to see if we'll be re-asking this question towards the end of our webinar today to see if Anne and Nanette, their findings corroborate with what you think towards the end of the webinar. And so again, this is the review and that Anne and Nanette will be speaking to today. And just as a reminder, the link to the full text of this review and our summary from health evidence have been posted in the chat. And so with that, it is my pleasure to turn it over to our to Anne and Nanette for you. So Anne, I have passed you the ball, and please take it away.
Thank you. And first part of this presentation will be covered by Nanette. Hello everyone, and thank you for joining this webinar. Good afternoon for us here in Scotland. This is a great process. We're delighted to be invited to do it. This is Nanette speaking now, and it's my job to give a short background and introduction to the systematic review. So the slide you have in front of you displays what might be globally now accepted as the recommendations for physical activity benefits for adults and older adults. But in fact, this infographic has been produced by the Chief Medical Officers of the United Kingdom, but it's a pretty useful resource that anyone can access. So you'd be very familiar with the left-hand side of that infographic saying, be active, and the minutes per week should be 75 rigorous or 150 moderate or some combination. You might also be familiar with the right-hand side of the slide. To improve balance and build strength, you need to do some particular activities on at least 2 days a week. We've all known that for quite some time. But what has newly crept into the global and European and these are UK recommendations is that people need to pay attention also to the amount of time they're sitting. So the recommendation is a bit more vague. It just says we should try to sit less and we should try to break up our sitting time. And it highlights watch television less, sit on the couch less, use computer less. But I don't want you to move away from your computer now because you'll miss the rest of the show. So stay with us while we go through the rest of it. But that gives us the rationale for why we've decided we need to focus on what we know about helping people to sit less. Okay. We're moving? We're not moving our slides. How do we move our slides?
Okay. If you look up on the top, you'll see the slide number and then an arrow to the right. You just click on the arrow. There you go.
We've got it. So next short task is to try and be clear about what we mean by sedentary behaviour. And here you've got a graph that shows you a spectrum of intensity levels of activity, with sedentary obviously on the left-hand side and vigorous physical activity on the right-hand side. Metabolic equivalents are giving us these different intensities. When we're sitting, it's roughly 1 metabolic equivalent, and if we were up and walking the dog, for example, it might be between 3 and 4 metabolic equivalents. So the researchers around the world have set themselves on this particular definition. Sedentary behaviour refers to any waking activity, so we exclude sleeping time because sleeping is nurturing and beneficial. So it's waking activity characterised by low energy expenditure of less than 1.5 metabolic equivalent, and the person is in a sitting or a reclining position. And just to confirm that, I want to say that it's different from a sedentary lifestyle, and I think we're still a bit confused in the literature. A sedentary lifestyle has been used to try and explain someone who isn't very physically active. But sedentary behaviour is a particular kind of behaviour, and someone can be quite active and still have a lot of sedentary behaviour. So sedentary behaviour, to confirm, is waking behaviour. We're sitting or lying, it's the dominant mode of posture. Energy expenditure is low, and typical activities that we undertake when we are doing sedentary behaviour are screen time, when we're driving in motorised transport, sitting at work, sitting to read, talk, listen to music. Now, the next slide is one of the most recent meta-analysis of the health risks of too much sedentary behaviour. And while I'm saying that we don't have nearly as much evidence in this direction as we have for the health benefits of being physically active, it is exponentially increasing and is becoming more and more convincing. So this particular piece of research shows hazard ratios of the amount of sedentary behaviour versus the typical health issues such as all-cause mortality, cardiovascular disease, incidence and mortality, cancer mortality and incidence, type 2 diabetes. And the very highest hazard ratio there is with type 2 diabetes. And I think this is helpful to see because really that's the tolerable mechanism. When you're sitting, we are not influencing our metabolic system at all. Muscles are not active, and so that system might be the first to be harmed by too much sedentary behaviour. So these effects are largely independent of physical activity, but we see higher hazard ratios when people have low levels of physical activity. And to put this in the context of the study that's funding our systematic review here in Scotland, we had a very successful programme called Football Fans in Training. You can see it on the slide there. It was this is the football version which you call soccer, and it's our national game. Men were attracted to attend their local football club, and they had to be overweight to enroll in this programme. The full results are printed in that Lancet article authored by Kate Hunt, which you might want to go and pursue. But if we just go to the next slide, we had a randomised control trial, and with over 700 men in total, the intervention group there in blue, 12 months after starting the programme, had lost 5.6 kilograms, whereas the comparison group had lost only 0.6. So very successful in terms of weight loss, and you'll realise that 12 months of sustained weight loss is a difficult thing to achieve, so we're pretty proud of that. Also in that study, we had self-reported physical activity, and again the intervention group had much higher levels of self-reported physical activity in comparison to the comparison group at 12 months. So we were quite encouraged by this, and we then applied for some additional funding to take the Football Fans in Training concept into Europe. And this is funded by a special European research fund, and you can see that it's called Eurofit. Again, I've given you links to a variety of bits of information from that. But Eurofit is a social innovation using the football club to attract men in particular
cardiovascular, to improve the physical activity, and now also to decrease the sedentary behaviour, because they realise that this is a key issue for health also. The principal investigator for that study is Sally White from the University of Glasgow, and again I've given you links to that study. So our part in that study, myself and Anne, is work package 1, and you can see the first thing we have to do is a systematic review of what we know, and this is what we'll report on today. The second thing we're doing is looking at BCTs. We are calling them behaviour change techniques to help us identify what kind of skills we need to use to help people change thinking. And we have designed the Fitbit device. So my last slide, I think, coming up now, is to show you this particular device designed by PAL Technologies that gives people real-time feedback, not only on their steps, but also on their minutes sitting and their minutes standing. And this is a novel technique to help people self-monitor their sitting behaviour. So this is the context of how we came to be doing the systematic review, and I will pass the ball back to Anne to continue now with the details of the review. Thank you.
So we use the Fitbit acronym to define the focus of the sedentary behaviour review. And so the aim of the systematic review was to gather the evidence and to evaluate the evidence on intervention with the potential to reduce sitting time in adults, so that's our population of interest. In terms of defining the intervention, we were interested in any type of intervention which included a sedentary behaviour outcome measure, because sedentary behaviour research is a fairly young field, and so as we don't know what is a sedentary behaviour intervention, we were interested in any type of intervention. And as it turns out, it's mainly physical activity intervention, but also combines dietary, physical activity, and sedentary behaviour intervention. And we were interested in papers that compare those type of interventions with either no comparison group or with a control condition that were placed on a waiting list, or a control condition that we call attention control. This is, for example, where the control group would get a information leaflet about general health. For example, could be health checkup, or smoking, or alcohol, so very general non-physical activity information leaflet. Then eligible control conditions were also usual care systems, for example, for treatment of care of diabetic patients where lifestyle counseling is part of the routine care. That is also eligible as a control group. And then we also included a study that compared interventions we were interested in to alternative treatment conditions, for example, a structured exercise program. And then as our intervention criteria is any type of intervention which included the sedentary behaviour outcome measure, we had to define what kind of sedentary behaviour outcome measures we want to consider as eligible for inclusion in the review. And so we included any study that reported objective measures of sedentary behaviour or sitting time, so that could be either posture measures, like say from an inclinometer, like the active power, or total sitting time, say from accelerometer. But we also included studies that reported sitting time from questionnaire, so self-report total sitting time, or self-reported sitting time from proxy measures. And proxy measures we consider estimates of sitting time where we believe people spend time sitting. For example, it could be the time spent watching television, or time spent commuting by car to work, or these kind of proxy measures where we believe people sit while they do the activities. And then move on to the next slide. We'll give you a brief outline on the next couple of slides I will talk about. So before I move on to the methods and the findings of the And then I also talk a bit more about the method and the risk of bias we identified in the study. And then I conclude this presentation with implications of our findings for practice and research, and I give you an overall summary, and then after that I give the whole back to Jenny. So what other reviews have been published in that area? So one review by Prince and colleagues was published in 2014 in Obesity Review, and they looked over at interventions with the potential to reduce sedentary time and included both randomized control trials but also non-randomized control trials. And they found that interventions with a specific goal of increasing physical activity and interventions that combine an increase in physical activity and a decrease in sedentary time had a modest reduction in overall sedentary behavior. And they also concluded that the greatest reduction of sitting time was present from interventions that specifically focused on sedentary behavior. And another very recent publication, which is a Cochrane systematic review of workplace interventions with the effect on sedentary time, was published by Fresma, and they found that sits themselves have the potential to reduce sitting time between 30 and 120 minutes per day, while the quality of the evidence was very low to low. And any other type of intervention, for example, computer prompts to break up sitting time, or rearranging the workplace in terms of changing organizational structures, there is not a convincing effect on changing sitting time. So that gives you the context of other reviews. And so what have we done? So we searched 13 databases and trial registers for randomized control trials. So we were interested in the highest level of evidence to minimize the bias within the study design. And after removing duplicates, we screened almost 6,000 records, and we screened with more than 200 full-text articles, and we included 51 studies in the systematic review, and of those 51 studies, 36 studies could be included into the meta-analysis. Having said that, you will find the big picture that I present in the next slide has 34 studies included, and 34 studies presented sitting time in minutes per day in their report. So, before I talk about the findings of the review, I give you a brief overview of the risk of bias. So here you see the risk of bias graph from the Cochrane collaboration using the risk of bias tool. And in green you find the proportion of studies with a low risk of bias. Yellow refers to studies where we couldn't really determine the level of bias, so often because it was not sufficiently reported. And red refers to a high risk of bias, and the type of bias is really assessed where selection bias, performance bias, detection bias, attrition bias, and reporting bias. So, and as you can see, for detection bias, there are very big red bars, which indicate that more than 50% of the studies we included were at high risk of detection bias, and this is mostly due to the fact that most of the studies use self-report measures. So when participants of studies are aware of what they report, namely sitting time, there is a risk of under-reporting and also recall bias if people don't remember how much they were actually sitting. So therefore, there is a risk in under-detecting the actual intervention effect. I will come back to the implication of that bias when I talk about the different tools used in the studies included in the meta-analysis. So now the next slide shows the findings that you see the big four, but I'm not expecting you to understand and grasp into everything that's shown here. But what I want to ask you is to draw your attention to the bottom left diamond, which shows the overall intervention effect. And so the overall intervention effect refers to the effect of 34 studies, regardless of the type of intervention. And we find that it is possible to reduce sitting time by 22 minutes in the intervention group compared to the control group. But, as we know, there are really different types of interventions. So some studies asked participants to increase their physical activity level. So they specifically looked at or targeted increasing physical activity as opposed to reducing sitting time. And the finding of the physical activity interventions is shown in the top diamond. And we see as the diamond is crossing the line of no effect, we see that there are studies that specifically targeted increasing physical activity do not result in a significant reduction of sitting time. On the other hand, studies that specifically target the reduction of the sedentary behaviour, they do reduce sitting time after the intervention in the intervention group compared to the control group. Having said that, there were only 2 studies included in this review. So only 2 studies specifically target sedentary behaviour, and the intervention effect was 34 minutes. So those 2 studies, as a total effect, managed to reduce, the 42 studies, 42 minutes per day, sorry. And then there were also studies that combined both. They asked participants to increase their physical activity level and to reduce their sedentary behavior. And there were only 3 studies included of that type of intervention. And those studies did not result in a significant reduction in sitting time. Then there was a big group of studies that we labeled lifestyle interventions. And what we mean by that is interventions that target the physical activity, sedentary behavior, and a dietary component, so either a nutritional component or general changing dietary habits. And as a whole, those interventions managed to reduce sitting time by 24 minutes per day. But we also found that because these interventions were so different, there was a high level of variability between the studies, and so we wanted to have a look, or we did look at different study characteristics, like the size of the population, the intervention duration, follow-up duration, and the setting in which the intervention took place, also the assessment tools used, to see what could explain the variability. And so we found that the heterogeneity variability is partly explained by the intervention duration and the effect of study participants. So an intervention of up to 3 months was most effective, so resulted in significant change in sitting time in favor of the intervention group. And any intervention longer than 3 months did not result in a reduction of sitting time. And so in terms of the total population, interventions targeting men specifically managed to reduce sitting time, but in women there was a similar effect, so there was no statistically significant finding. Mixed sex studies also reduced sitting time. So when I'm conscious of time, I'll move on to the next slide, which really summarizes the quality of evidence, because besides assessing the risk of bias in a study, it also assesses the overall quality of the evidence outcome level rather than study level. And overall, we found that the lifestyle interventions were of high to moderate quality. Studies that specifically targeted sedentary behavior were of low quality. And that is mainly due to the fact that participants couldn't be blinded, and also not the personnel who delivered the intervention, and to the true purpose of the intervention, because the study targeted sedentary behavior, personnel and participants were aware of the purpose, which was reducing sedentary behavior. So therefore we had to rate these studies as high risk of performance bias. Physical activity and sedentary behavior interventions, as well as specifically the interventions that specifically target physical activity, were of moderate quality. So what implications do these findings have for research? So first of all, a secondary outcome of this systematic review was also to determine whether those interventions had an impact on health outcomes. We were interested in cardiometabolic markers, in anthropometric measures, and also mental health. And we should say we did not have enough evidence to draw any conclusions on that. So the studies that specifically targeted sedentary behavior did not assess any of these health outcomes, and for studies that did assess the health outcomes, there were physical activity and lifestyle interventions. And so we don't know its impact on health outcomes was related to the physical activity or any other intervention component or the sedentary behavior component. So, and then also studies that managed to reduce or benefit health outcomes, most of those studies actually did not reduce sitting time. So overall, we don't have enough evidence, and we need more research in that area. And just reference recent publication by Nanette and colleagues from Denmark, who conducted the sedentary behavior intervention, and they found benefits in reduction of weight circumference and weight, and an improvement in insulin sensitivity. So if you're interested in those findings, have a look at the paper. And then also in terms of implications for research, we need more intervention, sedentary behavior, specific interventions, so that we can tell what is most effective and how can we help people to change sitting time. And then, as I mentioned earlier, we need to know, and this is what we're in the process of, we need to know the active ingredients, so what behavior change techniques should be employed to help people to reduce sitting time. And in that context, we conducted, we evaluated the intervention components very thoroughly, all the interventions being included in that review. So we conducted an update search, because the field is growing and growing, and more evidence is available. And I like to share the findings of the update search with you. So first of all, what we found is that the numbers of studies published between January 2014 and February 2015, when we did the update search, increased by more than half. And so there are more physical activity interventions included, more physical activity and sedentary behavior interventions, but also a bit more sedentary behavior only interventions. So out of the published review, we had 2 sedentary behavior interventions. Now the update search shows 4. And overall, we can confirm with the update search, we can confirm the findings of the published review, so the effect of sedentary behavior interventions and lifestyle interventions on sitting time. But what we also see here now, mainly due to the increased numbers of studies included, that physical activity and combined physical activity and sedentary behavior interventions can reduce sitting time, but to a lower extent for physical activity only interventions. The implications for practice are that, based on the published findings, we cannot give specific recommendations to the degree of the reduction of sitting time that is required for health benefits. But the findings could encourage clinicians and public health practitioners to give advice about reducing the total volume of sitting time and also to break up prolonged periods of sitting time. But at the same time, this advice does not replace advice on physical activity, increasing moderate to vigorous physical activity levels. And what we also need to consider is identifying the barriers and facilitators of sedentary behavior and what can help people overcome these barriers and use those facilitators. Summary. The published systematic review indicated that it is possible to reduce sedentary behavior by 22 minutes per day, and lifestyle intervention seems to be a promising approach with moderate to high quality evidence, and targeted sedentary behavior intervention resulted in the greatest reduction of sedentary time by 42 minutes per day. Interventions duration up to 3 months can produce significant reductions in sedentary behavior, and with evidence that this intervention effect lasted up to 12 months after the intervention finished, which is quite encouraging finding. But we need more research to determine if sedentary behavior interventions are sufficient to produce clinically meaningful and sustainable reductions in sitting time. And now I'd like to throw the call back to Jenny.
Great. We will now give some time for questions. So if you do have a question for Anne and or Annette, please post your question either in the chat or the Q&A. Please type it in, and then I will ask it of our presenters today. And so while we give you a moment to come up or ask your question in the chat or Q&A, we would just like to know now, what do you think after hearing the results of the systematic review presented? Do you, and again, most people agreed or strongly agreed before, but do people think, what do they think now about 10 interventions reduce sedentary time in adults? And so still the majority of people are saying agree or strongly agree. We do have some more neutrals and a disagree now. So quite interesting to see, I think, especially for myself, and Anne and Annette, maybe you could comment on that as well. Interesting to see how people's thoughts changed just based on the presentation of findings today. So thank you. And we'd also like to get your sense on whether you agree with the findings of this review. And just as a reminder for anyone who had not checked out the review on health evidence, it is a highly rated systematic review on health evidence, so it is of good quality. So just wondering, do you agree with the findings of this review? So most people do agree and strongly agree. We have some people who are neutral to whether they agree with the findings of this review. So thank you to all of you who have answered our polling questions. And what we'd now like to do is, as I mentioned, open it up for questions. And so thank you so much to those of you posting questions. So we do have a question, Anne and Annette, from Mary Lynn. And Mary Lynn is wondering, are there any specific guidelines for us to recommend to clients? Oh, sorry, my screen disappeared, so I'll try that again. So Mary Lynn would like to know, are there any specific guidelines for us to recommend to clients? For example, get up and move for 5 minutes every hour or half an hour, etc.
Universally, there are no agreed specific guidelines yet. The evidence is just not there to support something so specific. What the evidence guides to is reduce total time, if you can, and break up sedentary time if you can. And when we're working with clients now, we tend to use the once in an hour at least get up from your chair if you're working with a computer or if you're watching television. That kind of ballpark figure is the best we can do at the moment. Some countries have given guidelines for their children. In Australia, they suggest no more than 2 hours of sitting time at any one point. That's the only country, I think, that's got specific guidelines yet, although I know that Canada will certainly be working on it and already made a recommendation. But my point of view is that we just don't quite know enough yet to be specific about how much time is bad and how often you have to break it up.
Great, thank you so much. And we have a question from Kelly, and Kelly would like to know, what are your thoughts on the development of more specific guidelines for daily sitting time? So I think this quite well flows from the question that was just asked.
My thoughts are that in the next 2 years, as Anne pointed out, we've seen a doubling of the number of studies in terms of interventions in one single year. And we need more epidemiology as well that accurately measures sitting time against health risks and is able to break it down and help us with the number of hours that are seen as harmful. So I think over the next 5 years, we will be seeing these guidelines developed globally and in each country taking a role. We just have to wait until the evidence properly accumulates. There's a rough idea amongst researchers that perhaps 8 hours of sitting a day is risky, and that people who are doing that should seriously try to reduce that amount of time. But it's still preliminary to go with that threshold. We just do not yet know.
Great, thank you so much. And Nicole has a question, and Nicole would like to know if you can provide some examples of the interventions that were applied in the system, in the evidence that was included in the systematic review.
Yeah. So, for example, one of the specific sedentary behaviour interventions was a workplace intervention where the participants had a kind of a software installed on the computer that blocks the computer screen after 30 minutes. The screen was blocked for a minute, and participants were asked so that they were written on the screen, please stand up and break up your sitting time and do some activity. And then after a minute of blocked computer screen, they could go back, and this happened twice an hour over a certain time. And this, that was one example. Another example was for combined civic activity and set of behaviour interventions with kind of advice given again to break up sitting time after a certain period of time and to walk longer distances or try to reduce watching television time. That is also one of the intervention strategies. Also, some interventions employ the whole family approach where they encourage parents to be more active with the kids and so not to spend so much time at home watching television or playing computer games. So, this is some examples of interventions.
Great, and a bit building on that, there's another question from another participant. We're asking if any of the interventions were geared specifically for the workplace. Were there any promising interventions for the workplace setting?
I can more tell about the update research rather than the one we've published because the more recent evidence on workplace interventions comes from the last year, where we've seen those workstations, like you sit down at desk, and more thoroughly since with consultation and motivational interviewing and advice how to overcome barriers and changing, kind of meeting culture of not just sitting around at meeting tables, but also standing or having walk and talk meetings. So these kind of interventions show promise in the workplace.
Great, thank you. And we have another question regarding the effect in terms of time. And so Robert would like to know, or is commenting, looking for a response. If I'm right, we see a loss of effect after 12 months. So he is wondering, what should we do to have the effect remain or can sustain that effect?
It's a very good question. I think we need to go back and look very specifically into the active ingredients, as we call it, and if the behavior change techniques are applied and employed over a specific amount of time. So as we know, habit formation can happen like between 60 and 66 days of an intervention, then a sustained effect can happen.
I think Anne's right. I'm jumping into health as well. I think she's completely correct. It's the exact same thing that happens with physical activity intervention. It's very difficult to sustain increases in physical activity beyond 12 months. And one of the ways that has been influential is self-monitoring, and of course with walking, a pedometer, and many people have this kind of app on their phone now. They can continually monitor what they're doing, and this helps sustain their motivation and helps it become a habit. And up until now, we haven't got a self-monitoring tool for sedentary time. And the study that we're doing in Europe with PAL Technologies producing a real-time piece of feedback for participants to see how much sitting and standing and walking they're doing might be key to sustaining changes in sedentary behaviour over time, because people then see it as habitual and they can monitor for themselves if they're doing their usual activity or usual standing up, or they're sitting down more than usual, and that would help sustain the change.
Great, thank you. And another question from Joe, again, continuing to ask a bit about the individual studies that were included, and please feel free to comment either on the original review or your update. But Joe would like to know, do many of the studies include or use older adults, 65 plus, as participants? And from that, if, for our studies, or are there any interventions suggested to reduce sitting time specific to older adults 65 plus?
Included in the review, we found that there is really not much evidence on that. So only a handful of studies specifically targeted older adults. And if you want to say more about the studies that are happening?
Yeah, we're involved in several studies actually focusing on older adults, because our preliminary work in this area suggests that perhaps, not surprisingly, they tend to sit more than the working age adult population, and we've been working on how to help them understand the meaning of that, and if it has health implications. It's a novel idea for the public to get hold of, that actually sitting, which many people might see as a way to recover, a way to relax, and when people are retired, they're often thinking they're putting their feet up, and to help people understand that this may not be the best thing, and instead to move their bodies more even in light activity seems to produce some health benefits. We're working on the meaning of that, and the interventions may involve encouraging people to have their own way out in different ways. Some of our participants thought of putting their cloakroom on the first floor instead of at the door, so they have to move up and round the house to do different things. So it's a new topic that we're really trying to work on from the participant upwards to see what sitting time exists, what meaning people have from it, and would they be acceptable to considering how to change it, to stand when they're answering the telephone, for example, and find routines that involve less sitting and more standing and walking.
Great, thank you. And we'll just give another moment to see if anyone has any additional questions. I do have a question, Anne and Nanette, and I hope you don't mind me asking. But in looking at the actual findings and the effects, I was wondering if you could comment, especially with the updated search, it seems that there's now statistically significant findings for all of the categories of intervention. Just wondering if you could comment in your expertise on the clinical significance of the reductions in time. Are these clinically important reductions in time, do you think?
No. So if you could answer that question over the time, answer that question because we don't have the evidence. So those studies did not look at clinical outcome measures. So we can't link the intervention effect of sitting time to intervention effect on health outcomes. Yes, more and more studies are being published and evidence needs to be synthesized to really answer that question. But based on individual studies, we can say that reducing sitting time can benefit weight and rates of confidence in a clinical manner and sensitivity and insulin sensitivity. So, for evidence are very.
So not enough evidence yet to have a new systematic review or meta-analysis just on clinical outcomes.
Okay, thank you very much. And I'm not seeing any additional questions, so we'll move on to wrap up. But again, if you have any last-minute questions, please feel free to post them in the chat or the QA. And so I would very much like to thank Anne and Nanette for talking about that research evidence piece of the model here for evidence-informed decision-making. And we do hope that being here with us today and hearing from Nanette and Anne will actually help you to consider this particular systematic review and research evidence perhaps in program and planning and policies moving forward. So thank you to our presenters today. And so just some thoughts on what you can do next. You can visit our website at Health Evidence, again, to access this systematic review or additional systematic reviews about public health intervention. You can register to attend one of our monthly webinars, our monthly registry updates. So you can get our monthly newsletter at Health Evidence by registering as a Health Evidence user. You can follow us on Twitter at Health Evidence on Twitter. And we encourage you to continue to spread the word within your organization about health evidence and systematic review level evidence. And of course, please feel free to contact us at info@healthevidence.org with any thoughts or questions or comments and even suggested topics for future systematic reviews to feature in our webinar series. So thank you. We hope that you will find this webinar beneficial. And at exactly the time of 12:30 Eastern Standard Time, it's my pleasure to conclude this webinar and thank Anne and Nanette for joining us today, and thank all of you for your participation and your wonderful questions. And I would just like to give a last comment, last comment or thoughts, Anne or Nanette, before we formally end our session today.
Well, we really enjoyed being involved and are very impressed by the health evidence approach. So we will certainly be sharing this with our colleagues, and we hope to be involved with you in future webinars. And thank you very much for inviting us.
Great, thank you. And with that, that will conclude our webinar for today. We hope to have our paths cross again in the future, and that will conclude. Thank you so much, everyone. Have a really great afternoon.